We're pleased to welcome now Dr. Dan Edney. He is the State Health Officer with the Mississippi Department of Health. Dr. Edney, always good to see you, sir. Thanks for coming in.
Oh, my pleasure. Appreciate the invitation.
Yeah, man. So we got the legislative session coming upon us.
Yes, we do.
Less than a month away. Seemed like we just died yesterday. And
it is busy.
And it was busy. And all the members that I see just, out in social events and so forth say, man, that last session was really a trying one. Won't be as long this time, so we got a month less.
This one's going to go quickly. You watch.
I think so, too.
It'll be over before we know it. But we've been busy the last 8 weeks preparing, going through our intersession meetings with leadership. It's really cranking up.
Yeah. So I know that besides the fact that you're responsible for the financial aspect, of course, of the Department of Health, right, and you pay a lot of attention to the economics of health care. You're also, as a physician, and just at your nature, I know you, that you're highly focused on the health of Mississippians as well.
Right.
And anytime I talk about this subject, I always try to kind of preface it with, there's health care and then there's health. And health care is more on the economic side of things, and health is a whole different matter. But how's our state doing from a health perspective?
And that's a great question. And what I do through these level meetings with elected leadership and then my public health chairs and my Medicaid chairs is I present the health brief, where I'm not going in asking for stuff, and I break it down into 3 sections. I present where we are with the health of the population, and then where are we with the health of healthcare, which is exactly what you're saying, the system, how we provide health care, the economics of it, and then the health of the agency and public health, and break it into those 3 buckets. And that translates pretty well. And, with the health of the population, overall, we're still struggling. We're still, comprehensively, we're dead last, and that pun is intended. We're dead last.
Yeah.
But we've got some sunshine, breaking through in some areas that I'm really proud to present. Maternal death is going down, infant death is going down, syphilis rates are going down.
Okay.
So we are elected leaders who make public health decisions through policy. There's only so much the Department of Health can do. There's only so much individual doctors and nurses can do. When you're talking about the burden of disease and death that we face, it's going to take all of us. And that includes elected leadership, legislative decision making, how we're going to invest our resources. And as we're looking at leading the nation in preventable death, meaning more Mississippians die every year unnecessarily than anywhere else in the country, the next question I've asked of my team is, how much does this cost? How much does this cost the 2 of us and your listeners?
Yeah.
How much to the economy of Mississippi does these really poor health outcomes cost us? And I commissioned a study through an independent health economist, had them look at heart disease, cancer, accidents, and added maternal infant death, and looked at those 4, $25 billion a year negative impact every year. And I gave you the study that that shows the formulas that we used. That's a lot of headwind we're facing. That's a lot of economic development to overcome that. So I'm saying, why not look at this as economic development? Because we're struggling with poverty. I'm 63 years old, and still my whole life poverty drives the bus in Mississippi.
No doubt.
Education and health, those 3 things are integrated tightly, and we're making huge progress with education, little progress with poverty, but our poverty rates are pretty stagnant. Let's go after health, because I truly believe health connects to wealth. As we're more educated as a population, as we're a healthier population, we will see a wealthier population. So instead of dumping money into poverty programs, just putting money into it, let's attack the root causes: education, health.
Sure.
And I truly believe that synergistic effect is going to lift the whole boat.
Well, $25 billion, as I recall, the state's GDP sits right at about 120. So this is a little less than 25% of our state. I mean, that's massive.
And it's and you're the first one who has connected that I've presented.
Okay.
Everybody's had this. Yeah, it's going to be a big number, but when you look at that negative impact compared to GDP, and I look at it as opportunity.
Yeah.
And so, stop looking at healthcare investments as lost money. Look at it as investment with an anticipated return on investment.
Sure.
So as we provide access to care for Mississippians, as we strengthen rural health care in Mississippi, as we provide better preventive care through primary prevention by us at the health department working with education to educate children better on how to be healthier, start early, and reduce our obesity rates, our diabetes, and rates of hypertension, you'll see heart disease go down. As all Mississippians have the chance to be screened for cancer like you and I have, we will see the death rate from malignancies go down. We have the highest rate of colon cancer deaths in the country.
Nobody should die of colon cancer.
It's preventable, right?
Right. I had it in 2006. I've told the story before down at the Capitol.
My father died at 56 of colon cancer. I was diagnosed at 45 with multiple polyps, which meant I was following my father.
Right.
I'm not going to die of colon cancer. I'm not going to get colon cancer.
Yeah.
Because I'm on
no reason
to.
Removing polyps is preventing cancer.
That's right. And then we've got to really lean into accidents because the accidents are a huge amount of preventable deaths at all ages. I'm real proud public service got the driver's ed back into the schools.
Yeah.
I think we have good partners with Dr. Evans at the Department of Education for us to all work together to educate K through 12. A lot of these safety issues, they just need to know a lot of basic how to be healthy. Not a health class, but just embed into the curriculum, teaching them about the dangers of obesity and what healthy eating looks like and how important activity, just the stuff that we stopped doing.
Yeah.
And now that'll be generational, but some of the stuff we're talking about, improving access to primary medical homes, everybody having a primary doctor or provider. They're going, they have access to know their numbers, see what their sugar is, know what their blood pressure is. Most people don't know when to start colon cancer screening at 45 now.
Yeah.
They don't know that we have great screening for lung cancer. We've got to work harder on our smoking rates, and I've been really talking about that at the Capitol. So a lot of opportunity, but us all looking at that 25 billion number and start chipping away at that, and I just think we're going to see poverty rates go down. Maybe it won't be in my lifetime, but Lord, we got to start sometime.
Oh, I think they're inextricably linked. I don't think there's any question about that. If you consider the fact that by most metrics we're the least healthy state, we're also the poorest state, I suspect there's a correlation there.
Absolutely. And I gave you the data. The next question I asked was, what's the cost of human capital?
Sure.
And went back to 1950 and looked at our mortality rates comparing to the U.S. mortality rates since 1950, and the difference between us and the U.S. average, not U.S. good, just U.S. average, through 2022, we have 218,500 people who are not alive, who would be alive if we just had average health metrics. And then you factor in the loss of reproduction, babies who died who didn't have families, children who died who didn't have families, gets more like 375. Jordan, that's a congressional district.
That's incredible.
Our population should be more like 3.3 million if we were just average.
From a mortality.
From mortality.
Improving on that.
That's right. Just making us average. So the closer we get to average, the more people live longer.
And produce.
Yeah.
Wow. You can hang around with us, can't you?
Absolutely.
We got Dr. Dan Edney, the State Health Officer, in the Element Well studio. We're coming right back. Studio with Dr. Dan Edney. He is the Mississippi State Health Officer with the Mississippi Department of Health. So it sounds like, Dr. Edney, we're making some improvements in some areas, but still got work to do in others.
We do. So I'm real excited. We're not where we need to be, but with maternal death, that is trending down. We just released, and I gave you a copy of our most recent Maternal Mortality Review Committee report. but it's for the COVID years. But if you pull COVID deaths out and just look at the baseline deaths, we're trending down with mortality rates there. The next question I asked my team, show me the babies.
Yeah.
I have to see the mortality trend, go back to 1950, show me the same thing for the babies. And I gave you that curve. It's a beautiful curve.
Okay.
And we are talking about small numbers. They're too large because these are our babies, but they're not in the top 10 causes of death.
Okay.
But our numbers are still too high. It looks like we're going to track down to about 8.3 infant deaths per 1,000 live births. That compares to about 5.4 for the U.S. average. So we're too high. But Gerard, it wasn't too long ago we were 10.8.
I remember that.
So we have tracked down. The forecasting for this year is looking favorable. So we are not taking our foot off the pedal, working with all of our partners to do everything we can do. The leading cause of infant death is prematurity, low birth weight, and that shows us we have a system problem because Alabama's leading cause is genetic malformations. You can't do a lot for genetic malformations. Sure. Early prenatal care helps, but if babies have a genetic issue, they have it. But most of our babies are dying from prematurity, low birth weight, which means it's multifactorial. But one problem is the high-risk babies not being delivered where they can have immediate access to a NICU.
Yeah.
So we're looking at a system of care where the high-risk births are occurring where there's immediate NICU access, but we have to look at all the hospitals and what their needs are, because the incentive now is financially is to deliver and then transfer, and we've got to flip that to transfer, deliver safely where the resources are, but make hospitals whole for making those good decisions, and they want to do it. The hospitals are all in on this.
Yeah.
So we're at the point now, the low-hanging fruit's been done. We've got to keep doing it. But now it's the heavy lift, things like OB system of care, Healthy Moms, Healthy Babies, home visitation program. I mean, we have a lot of work that we're doing that we have to continue to do. I think you'll see over the next 2 years with the system of care building out and perinatal regionalization occurring, which is a national standard for perinatal care, I think we will see those premature deaths go down.
How much of that's just lack of knowledge of
too much?
Yeah, right. I mean,
too much, because when you look at the deaths, about half of the deaths are occurring in women who did not seek prenatal care within the first half of their pregnancy. We want women in immediately to start receiving prenatal care, especially our Medicaid moms who are having the highest death rate because they're most vulnerable, highest risk. We need to be backing up before they're pregnant, make sure our young women are healthy before they're pregnant, help them make pregnancy choices in terms of when to get pregnant, and make sure that as they choose pregnancy that they have the resources they need to have a healthy, low-risk pregnancy and through proper family planning of contraceptives. And then have early access to prenatal care, so we get them on vitamins for the baby, we get them on aspirin if they're high risk at all, which reduces preeclampsia rates. Identify gestational diabetes and pregnancy-induced hypertension early and get that under control. And we will see maternal deaths continue to go down, and we'll see healthier babies being born.
Well, and not to mention the cost associated with that care, especially if you didn't receive the proper prenatal care, or you didn't conduct your lifestyle the way you should as a pregnant mom, and then that manifests as medical problems in the later part of the gestation period and the delivery and et cetera, like the low birth weight.
Absolutely. So the investments we're making now through the legislative direction of presumptive eligibility, that's going to improve infant mortality.
Yeah.
It just will. And the 12-month postpartum care, that's saving mothers. If you have diabetes and severe hypertension and you lose Medicaid at day 60, you lose your medicine. Well, now we got 12 months to keep them stable and look at transitioning them to alternatives to Medicaid, and through the exchanges if we need to.
Something we need to talk about, because
so those are two legislative wins that are saving lives.
Okay. Because, both of those were recent enactments, recent actions by the legislature.
We'll see the needle from that moving probably next year.
Okay. So you and I were discussing earlier that we've got this situation kind of hanging out there, the dagger over the head, if you will, of the expiration of the enhanced subsidies in the exchanges. And you were sharing with me that the results of Mississippi really outpaced the rest of the country in terms of just increase of those enrolling in the exchanges and obtaining their insurance through these enhanced subsidies. And
I can tell you as a doctor, but when I was in private practice, the exchanges were pretty much catastrophic plans. They had $8,000 deductibles. If you got in the hospital, it would burn up that deductible. But in terms of just going to the doctor and getting screening done, they weren't very helpful. Then with enhanced subsidies, those deductibles drop way down. And so now the awareness is there, as you have been promoting, and the uptake of the exchange plans have been going up for those who have been eligible but just didn't know it. And we have invested a good bit at the Health Department to do eligibility determination for Medicaid and for the exchange plans for the people we serve, because I'm taking care of 40% uninsured population. I know at least half of those folks are eligible.
Yeah.
But, man, if you've never signed up, if you've never gone through healthcare.gov, it's a chore.
It is. I agree.
So we know our folks need help, so we are investing in navigating our population who are eligible to get on Medicaid or to get on an exchange plan. But there's still a gap there. There's about 20% of our folks that are still – we can't get them on anything.
That's right. Your income has to be 100% of the federal poverty level or north to qualify for subsidies in the exchange.
Right.
For Medicaid, if you're not in one of the existing coverage groups, it's way down at 25% of the federal poverty level. I mean, it's $4,000 a year. So the gap between the $4,000 and the $15,000 and change, which is 100%, is where we have this.
That's exactly right.
Yeah.
And for us, this is not esoteric. This is real life for us because we run into it every day. A cohort of folks that come to us for care who just aren't eligible for anything with our current policies.
Okay.
And so when we look at that $25 billion a year as we invest to close that gap, there we go. We start chipping away at that $25 billion
You're talking about the economic, just to remind folks, the economic impact of our poor health, essentially.
Right. So we make the investment on the front end, we get the rewards on the back end, but we'll get the rewards. I mean, be sure of it.
When you're delivering that message, Dr. Edney, are you getting a receptive response, if you will, from our lawmakers? I mean, do they understand this is a legitimate problem? Do they accept the analysis?
They do, but because I tell them I didn't expect to see the analysis. The other thing you'll see, the study I gave you, is increasing trend of mortality in Mississippi and the separation further from the U.S. average.
Okay.
So the disparity between our whole population and the U.S. average is widening. Our mortality rates are going up. I wasn't expecting to really see that. And I've asked my colleagues in Alabama, Oklahoma, Tennessee to look at their numbers and see what their trends are because they haven't looked at that either.
Interesting.
That got my attention. And it's getting the attention of our decision makers. And I'm just begging them, as you're making healthcare policy, remember this trend.
Yeah.
We cannot leave this trend. It's not going to fix itself, Gerard.
Yeah.
It will not organically correct. This is going to take thoughtful policy, strategic investment to attack that excessive mortality rate and chip away at that loss of GDP.
Well, that is an interesting set of data points that I don't know I've ever really heard presented the way you have here today and the way you have been presenting it to those responsible for policy making. And again, I think we got enough smart people in the state that we can sit around and whittle out some solutions to this. I really do believe that.
Absolutely. We've had good solutions come before us the last few years. We just got to close the deal and take care of our folks.
Yeah.
We can do this.
I agree. Dr. Edney, appreciate you coming in. I always enjoy seeing you. Yes, sir. Thanks a lot. We're coming right back in the